everyone. I'm Rachel Werner. I am the Executive Director of the Leonard Davis Institute for Health Economics. Welcome to today's seminar on understanding private equity in healthcare. As many of you know, private equity is gaining a strong foothold in the U.S. healthcare system. And while private equity began investing in healthcare several decades ago, it's really been over the past decade that it's started to grow more quickly. In 2010, there were 325 private equity deals in the U.S. In healthcare. By 2021, that number had soared to well over 1,000. And the Kaiser Health News found that private equity firms had invested nearly $1 trillion through thousands of deals to acquire hospitals and specialized practices in the past decade alone. So the presence of private equity in healthcare is definitely the subject of controversy. Patients, healthcare providers, and policymakers spend a lot of time worrying about what the short-term financial incentives are and how they might shortchange patients, result in consolidation in the healthcare markets, increase costs of care, and perhaps worsen patient outcomes. It's even drawn the attention recently of the White House. But what is the evidence to support those concerns? Today, we have invited 4 experts in private equity to help us try and unpack private equity's intricacies and understand its effects on healthcare. First, we have Atul Gupta, who is an assistant professor in healthcare management at the University of Pennsylvania and a senior fellow at the Leonard Davis Institute of Healthcare Economics here. We are also joined by Sabrina Howell, who is an associate professor of finance at the New York University, a faculty research fellow at the National Bureau of Economic Research, and a research fellow for the Private Equity Research Consortium. Ryan McDevitt is a professor of economics at Duke University. He is a faculty affiliate for the Duke Margolis Center of Health Policy and a research associate at the NBER. And Brian Powers is the vice president of clinical strategy at Humana, an assistant professor of medicine at Tufts University School of Medicine, and a practicing internist. Thank you all for joining me so much. Sabrina, I would like to start with you. You have a lot of expertise in private equity as a financial economist, and I thought it would be helpful if we could start with a little bit of a primer on health equity. Could you give us a little bit of an overview about what health equity is and how it's distinct from things like leveraged buyout and venture capital?
Thanks a lot, Rachel, and it's great to be here. Although I should say I have a bit of a cold, so you're probably glad that we're not all in the same room, but I'll try not to sound too congested. So private equity encompasses a very large asset class. What it always has in common is that private equity firms are financial intermediaries. They take money from mostly institutional investors. Think about pension funds, endowments, or sovereign wealth funds. And then they in turn invest that money into private companies or other assets like infrastructure or real estate. Now, the investors, like the pension funds that are providing the capital, are called limited partners. And their money goes into particular funds that the private equity firm is in charge of, which usually have a 10-year lifetime in which to invest. In the US, private equity basically comes in 2 flavors. One is growth equity, which looks more like venture capital, where the private equity fund buys a minority share of the company, so they don't obtain control. And the money that they invest is used by the company for growth. There's a lot of growth equity in healthcare, but it's more on the tech side. The other flavor is the leveraged buyout, or the LBO. And I think that's what we'll focus most on in this panel, because it's the dominant transaction type when it comes to purchasing healthcare providers. And it's where I think there's more controversy, and concern about sort of possible negative effects. Now, in an LBO, a target firm, like a physician practice, is acquired primarily with debt financing. And that debt is placed on the target company's balance sheet, along with a small portion of equity that's mostly coming from those limited partners. So after the deal, this company that was just bought by the private equity firm owes a lot more debt than it did before, which it has to service. So overall, this type of private equity ownership after an LBO leads to different financial incentives and business strategies than other types of for-profit ownership, like independent firms or even publicly traded firms. Private equity owners have what we call higher powered incentives to maximize firm value. And in my view, there's sort of four reasons for this. One is the high leverage, that is the debt load placed on the company that I talked about. The second is that fund managers get compensated through what we say a call option like share of the profits. The third is that because of the 10-year fund lifetime, the managers aim to sell the investment, to liquidate it within a pretty short time frame. And then finally, and this one is a little squishier, the private equity managers don't have existing relationships we might think of as implicit contracts with target firm stakeholders, like customers, the government. So overall, a modern private equity deal we should think about as not really being successful if the business continues as is. So this is going to motivate aggressive and more short-term value creation strategies. While a traditional business owner, even like a publicly traded firm, will be running the firm as a longer-term going concern with less leverage, and therefore may prefer sort of lower but more stable profits. So I'll stop there, but happy to answer any follow-ups.
Yeah, so that was super helpful. I think that as a follow-up, I might ask you to comment on why you think we're seeing such a growth of private equity investment in healthcare and then in that sector specifically.
I think one answer is that healthcare is where the money is. That's why they say why robbers rob banks. As I think many of you know much better than I do, in 2021, U.S. health expenditures were 18% of GDP, which is more than manufacturing and energy combined. And then at the same time, sort of in tandem with these growth in health expenditures, the private equity industry has grown dramatically over the past couple of decades. So assets under management, which means like the value of all the portfolio companies that are owned by private equity, just for LBO funds, for these leveraged buyout funds, was over 2.6 trillion in 2021, about half of which was in the US. So, think PE investment in healthcare, a little bit more specifically, increased by over 10 times between 2004 and 2021, and was actually $150 billion in 2021. Excuse me. So, and then beyond this sort of market size point, that just it's a big market and PE is everywhere, so they're in this market, is that there are demand side and supply side factors that are contributing to this surge of private equity interest in healthcare. So on the demand side, many healthcare providers are sort of welcoming new capital sources as they're facing, financial pressures due to, squeezes, I think, from higher costs and perhaps lower reimbursements, particularly after COVID-19 started. And then at the same time are pressured to, get funding to upgrade technologies or expand. And it's getting harder for smaller independent companies to get loans from traditional sources. And then finally, I think physicians may be more interested in selling their practices as they sort of struggle to compete, particularly in recruitment, with practices that are owned by hospitals and private equity firms increasingly. And then on the supply side, private equity sees a lot of investment opportunities in healthcare. So one big dimension is the aging population, which is going to demand more medical services in the future. Another thing is that demand is historically fairly stable for healthcare, so that this sector becomes more resilient to downturns, and thus can be a really helpful part of a larger portfolio the other parts of which might be more cyclical. And healthcare markets are also fragmented geographically. Of course, many patients don't want to travel too far away to receive medical care. So that creates opportunity for private equity to use what we call add-on or roll-up strategies to consolidate a bunch of practices in a particular market and potentially benefit from economies of scale and market power in that area. And that's a bit speculative. There isn't really any evidence on that yet, although I'm hoping to do some work myself soon. And then finally, private equity can improve the efficiency of care delivery in some segments by bringing better management expertise and better administration. So this is another way that they can, in particular, increase value in healthcare.
And then one more question before I let you off the hook, which is, does private equity investment in healthcare raise concerns that don't apply to other sectors of the U.S. economy? We see private equity everywhere. Why are we particularly concerned in healthcare?
Yeah, so that's a great question. And it's a complicated one. I think that private equity firms are basically more responsive to competitive and financial incentives than other types of firms. That's like the base layer difference. And how that's going to manifest in real outcomes, like whether customers are better off after an acquisition, well, it depends on the incentive structure of the particular market. So my own view is that we should expect results to differ potentially dramatically, depending on the industry and even the narrow subsector. And consistent with that, the literature in economics and finance finds sort of mixed effects of private equity depending on the sector. So my read of this literature is that we know unambiguously that private equity ownership increases productivity. But whether the operational changes are good for consumers, and of course in healthcare it will be patients, depends on whether incentives to maximize profit are structured to be well aligned with consumer interests. So in competitive sectors, where you have transparent product quality, like it's easy to observe the quality of the product, and you don't have much government subsidy, we see positive effects. And examples of studies in particular sectors have looked at fast food restaurants and grocery stores and manufacturing. There we have some evidence of positive effects. Now, in my research, I've studied sectors where you have baked in poor incentive alignment and intensive government subsidy. And there I've seen, on average, negative effects. So I focused on these sectors where there's this really important role for implicit contracts or trust between stakeholders and firms. And, this often is the case is coming along with, heavily subsidized sectors. So I've looked at for-profit colleges, nursing homes, local newspapers, and airports. And for the first three, I find evidence of adverse effects of private equity ownership along at least some dimensions. And for airports, we find efficiency improvements are stronger when there's a competing airport nearby, suggesting an important role for competition. But overall, because of the way airport economics are set up, we actually find positive effects of private equity in the context of airports. So overall, I think my research together with other research on private equity in healthcare suggests that, in sectors without competitive markets, particularly where you have a lot of subsidy and you have vulnerable consumers, may be associated with more adverse effects of private equity buyouts. And I think, a tool can hopefully speak a little bit more to our paper about nursing homes. But, there is a case of really severe information frictions and misaligned incentives where government subsidy is separating revenue from the consumer. And there's a really low price elasticity of demand. You have costs that aren't sailing it. You have really opaque care quality. And that contrasts, as I understand, and I'm not at all a healthcare expert, but with, something like maybe dermatology, where you have consumers that are more sophisticated, who are paying more out of pocket. They have more choice, maybe more ability to assess quality across that appointments sort of dynamically. And I wouldn't be surprised, if you saw sort of quite different effects, more positive effects of private equity buyouts in dermatology than, in nursing homes.
Okay, that's super helpful. And so that was a great segue, and we can turn to Atul next. So Atul, you and Sabrina and others have done research looking specifically at private equity firm investments in nursing homes. Can you tell us a little bit about what you found in that research as a starting place?
Yeah, definitely. And thank you so much for having me. This is a great forum. So just to give you a quick summary of what we found, we looked at what happens when nursing homes are bought out by private equity firms. And our headline result is that unfortunately, for Medicare patients, who account for about 60% of all patients that pass through nursing homes, mortality, short-term mortality within 90 days of discharge from the nursing home goes up by about 10%. In addition to this, we also find adverse effects on other measures of patient well-being. For example, scores on mobility go down, scores on ulcers and pain. So we find sort of a coherent, consistent picture that patients are doing worse after the nursing home is bought by private equity. At the same time, we also see evidence that the nursing home spending goes up for Medicare. So I believe that we found an increase of about 6 to 8% in the amount that was spent on a nursing home stay. So that's a quick summary. I'm happy to give more if there's time. But I'll stop there.
Yeah, so I would like to follow up on that. And I think your results are interesting, and they really speak to some of what Sabrina was talking about in terms of the characteristics of healthcare markets in which private equity might be particularly harmful. Are there potential benefits? And so, as you know, that in the nursing home sector, there have been some other studies, particularly during COVID, showing that private equity owned nursing homes fared a little bit better. Can you talk a little bit about the trade-offs there, or what you think might be going on?
Yeah, no, for sure. I think there's a couple of things I'd like to preface this with. So first of all, I would say that the effects of private equity, even on nursing homes, what we found in our study, I wouldn't say that's the last word, right? There's, I think, a lot more that needs to be done to fully understand the effects of private equity ownership. And I think here, one of the things that Sabrina said is very important to keep in mind. Private equity firms are not inherently evil. They just have higher powered financial incentives. They'll respond to those financial incentives. And so in some places you might find positive effects, in some places you might find negative effects. That's also possible within the same sector. So for example, you mentioned nursing homes and how some studies have found positive effects during COVID. So there could be a lot of reasons why our results differ. First of all, our study did not cover the COVID period. Our sample period ended in 2016. So that right there is actually a big difference, even more than what it sounds, because it's not just that the years are different. The set of nursing homes that are owned by private equity could potentially be quite different, because private equity firms only own nursing homes for about 5 to 6 years, and then they actually divest. So the nursing homes that were owned by private equity in 2021 might be quite different than nursing homes during our sample period. And then secondly, I think we have to think about COVID as perhaps a slightly different time frame, in the sense that there was a lot of scrutiny on nursing homes during COVID because of obvious reasons. And we know that private equity firms respond to competition. They will probably also respond to greater scrutiny. And so it's actually perfectly understandable why during a period where there was a lot of scrutiny on nursing home performance, private equity owned nursing homes actually did a better job on some dimensions.
Yeah. Okay, so that's helpful context. Ryan, I want to turn to you next and talk a little bit more about evidence based on your research. And so you found that the role of private equity in the hospital setting differs a little bit, in contrast to what Atul is describing in nursing homes. The effect of private equity was a bit more positive. So if you could just tell us a little bit about what you found and what you think is driving that.
Yeah, thank you for the question. It is a great contrast, I think. And the framing for us is, we should look at PE's influence in healthcare, not just as simply good or bad. It's going to be important to look at each provider community specifically, whether it be nursing homes, physician practices, dialysis clinics, acute care hospitals, because the issues raised by PE acquisitions, they may vary a lot across the different sectors. And so on top of that, it's not right to think of PE as a uniform generic investor. There's a wide spectrum of different investors and strategies. So of course, you're going to see some heterogeneity in outcomes across different sectors and different types of investors. Okay. But as for our empirical findings in acute care hospitals, the first thing to note is, despite a lot of these recent headlines about bankruptcies in PE-acquired hospitals, the data don't actually support that narrative. There's not a widespread financial instability after the PE acquisition. The studies I've seen in some of our own work is, on average, these hospitals actually improved their financial performance after being acquired by a PE fund. And they did it by both reducing costs and increasing revenue. And there seems to be this odd tension between policymakers wanting to bend the cost curve by making hospitals more efficient, but then they seem to be vilifying PE firms when they do just that. And so there's this weird tension going on that we're trying to resolve a little bit with our own empirical work. And to drill down on that, in terms of increasing revenue, the PE acquired hospitals tend to shift their focus from outpatient care to more lucrative inpatient services. They're quicker to adopt profitable, more technology intensive service lines like cardiac cath, advanced imaging, robotic surgery. And I'd say perhaps most notably, we don't find any evidence of significant reductions in the most unprofitable service lines. So it's not like they're cannibalizing the stuff that's not making a lot of money. Maybe it's more valued by the community. We see this in addition to what they've already been doing.
Do you see, so one of the questions that's come up in the Q&A is whether or not private equity impacts, or how it impacts uninsured and underinsured individuals. Do you see any change in patient mix at hospitals that are acquired by PE?
Actually, we don't find any evidence of cherry picking, cream skimming, however you want to frame it. We haven't found much evidence of that at all.
Okay. And okay, so that's super helpful. Brian, I want to loop you into this conversation. As a physician and as the Vice President of Clinical Strategy at Humana, you offer a unique vantage point of the payer and the insurer on the rise of private equity in healthcare. Tell us a little bit about what your view is of private equity in healthcare, and particularly what the impacts are for payers.
Yeah, thanks, Rachel. Yeah, thanks for having me. Thanks to my fellow panelists too for really informing a lot of our view on this through your research. I would say our vantage point as a payer is really not dissimilar, I think, from some of our colleagues who are policymakers or sort of the societal perspective at large. And we are deeply concerned and cognizant of the affordability of care for our members and the quality of care for our members. So concerns and questions over the extent to which that is impacted by private equity investment is chief of mind for us. And I think we really didn't quite know until probably the past 5 to 10 years of research what those effects were. And I think what we've seen is really what, again, our colleagues here have summarized well, which is there's pockets of concern around poor outcomes for individuals, in our case, for our Medicare Advantage or Medicaid or commercial beneficiaries, or higher cost, maybe without a commensurate increase in quality. But there may also be pockets where that is less of a concern. And so I think for us, it's staying aware of the cost and quality impacts at a system level.
Okay, and maybe I'll ask you just to follow up a little bit on where you think the benefits of private equity are.
Yeah, I think one area that, at least for us in the Medicare space, that I think we have a little less research on, and so this is probably more anecdotal than anything else, but I think is worth considering, is in the primary care space. So as we think about our partnerships with some primary care organizations, we do have successful partnerships with a number of primary care organizations who've been able to grow to serve more seniors through largely growth equity financing. So Sabrina sort of laid out the distinction early on about the LBO buyout model versus growth equity model. So this is much more in that growth equity camp. And that's, to me, I think we've talked about the potential advantages from a efficiency perspective, potentially a quality perspective. I think there's mixed evidence there in specific circumstances. One, I think, as I sort of take back on a system kind of capacity and innovation perspective, I think a potential benefit, again, more research to be seen, and this is largely anecdotal, is the access to growth capital. Does that allow innovative businesses to scale more quickly? Scaling value-based care, scaling any brick and mortar care delivery organization is extremely capital intensive. And the sort of traditional sources of capital, whether it's public markets, private debt markets, create some capacity constraints there that growth capital might overcome. So I think that's one area, one dimension of potential benefits that I don't think is necessarily discussed as often, and we probably need to do a little bit more work on to quantify the benefits specifically.
Yeah, I might ask if any of the other panelists want to jump in on that idea that private equity investment really does help with innovation, with development of new care models, potentially things like that. I mean, I think especially, Brian, you mentioned brick and mortar care and expansion of that, but we're moving into an era where we're moving outside of brick and mortars healthcare, and is there a role for private equity in that as well? Go ahead, Sabrina.
I would just, mention that in the literature on private equity from other sectors, we do have a bunch of evidence that private equity increases investment in IT, digitization, and they're, really often bringing sort of best practices overall and new capital, to make investments that can ultimately kind of reduce costs by upgrading technology in the longer run. So I think that, in thinking about areas, thinking about remote care or digitization of records, that basically back office type stuff would be an area where I think that they could add a lot of value. And on the growth equity side, I think, again, it's a little bit more like venture capital, which we pretty much think is sort of unambiguously positive for the economy. And again, the money is being used to invest in growth rather than to finance the acquisition itself. And that's really a big difference. And I think there's just probably little to worry about, and potentially a lot of value that can be added.
And if I might just add to what Sabrina is saying, we're finding this as well on the technology side. Medicare has made it virtually impossible to remain viable without scale. Right? The reimbursements are pretty skimpy. The administrative burdens are quite high. And so you need scale to be viable. And that's one thing that private equity can provide. And not just private equity, any kind of corporate investor. This is why we're seeing consolidation. Riley League's a great PhD student at Duke. In his dissertation, he found that these higher administrative burdens are driving consolidation, at least on the Medicare side. So I think this all resonates with me and what we're finding in our research as well.
Yeah, one thing I will say is that, investments need not come from firms that are outside the industry necessarily. So I think a recent phenomenon in healthcare has been that a lot of the big players, like big insurance firms, big hospital systems, they've actually started investing. They've all opened up their own venture investing arms, and actually they've started investing as well in some of these new solutions, for example, for telehealth or digitization or analytics to improve how we can use electronic medical records and claims. And I think that solves one issue with private equity that Sabrina alluded to earlier, which is that private equity historically has tended to come from a sort of a sector agnostic perspective. They don't necessarily have any connections with the industry that they're investing in. It could lead to potentially a willingness to engage in behavior that perhaps a player from the industry would not. And I think that's something that's actually a positive development in the last few years.
So one of the things that a few of you have mentioned, but we haven't really talked directly about, is consolidation. And one of the trends that we have been hearing about in private equity is the frequent acquisition of small firms. And these are acquisitions that are small enough that they escape scrutiny by the FTC. So they don't meet the threshold for review. But there are enough of them that it begins to raise concerns about market consolidation. So I wonder if we could just spend a couple minutes talking about the effects of private equity on competition and market power, and how you think about these small firm acquisitions causing market consolidation. And Sabrina, I might start with you with that.
Yeah, sure. So, roll-ups where a private equity firm buys one sort of small company or builds an initial platform and then adds onto it other small firms is really a bread and butter strategy for creating value, in private equity. So like maybe you buy one grocery store, it's the anchor, and then you keep buying more and more and more in small transactions, and ultimately you build a big chain. Right, that's the model, and it's been applied to healthcare in recent years, especially I think for physician practices. And one important motivation for these types of deals is to reap efficiency gains by reducing administrative or back office costs, and that will typically result in a reduced workforce. That's not necessarily a bad thing. We don't necessarily need all that sort of redundant administration in healthcare. Whether it's good or bad for consumers, I think is a case-by-case question. So I guess, when we think about the acquisition of physician practices in healthcare, as you said, sort of each purchase doesn't hit the Hart-Scott-Rodino Act threshold for reporting the merger to antitrust authorities. And I think the consolidation that sort of occurred under the radar of physician groups is actually goes beyond private equity and has been occurring over time, as physician practices have generally become more consolidated. But so private equity is very involved in some of these transactions, and one reason private equity has particular interest in them beyond that sort of efficiency gains I talked about before is that the high leverage that they use is basically only possible for relatively large firms, or becomes easier with the larger the firm gets. And the what's called the multiple, or basically the sort of sale price relative to earnings that the private equity firm will get in a sale once it wants to exit the investment is going to be larger the bigger the company is. And so for these reasons, private equity has can actually gain a lot by just making the company larger, sort of independently of any efficiency gains. And so I think from this question of antitrust perspective, the roll-ups might be a problem, if the issue is sort of putting together many small firms and gaining market share, gaining market power. And in that case, I do think private equity and non-private equity should receive the same scrutiny. I don't think it's reasonable to single out private equity around roll-ups, sort of if this is a concern, sort of all buyers should be subject to it. And I think that in terms of what would happen if there were this sort of market power that was created in the local area, you might imagine higher prices, right? We might imagine that the monopolistic provider could reduce access or screen on more profitable patients in ways that weren't done before, or perhaps restrict insurance network participation. In order to reduce, increase profits. And there's some evidence I've seen that physician consolidation is associated with worse patient outcomes for Medicare. And then the most, I think, relevant paper here is by Thomas Wallman at UChicago, who studies this issue in the context of dialysis acquisitions, but he doesn't focus specifically on private equity. So I think there's definitely a room to do more and see if private equity is perhaps doing something different than other types of acquirers here. But I guess my general opinion would be that it's kind of a problem that potentially goes beyond just private equity.
Yeah, if I may jump in there, because this resonates with some of our own work in dialysis, and I think that's a perfect case study for this. We saw 30 years ago, the predominant model of delivery was an independent clinic. But now, 30 years later, we see two large chains. They own over 3/4 of facilities. There's been this dramatic consolidation. It has nothing to do with private equity, but more about the corporatization of healthcare. And so everything you mentioned, Sabrina, we found that in the data as well. Care gets worse. They cut back staff. They emphasize low-trained techs over high-skilled, high-wage nurses. We see death rates go up, drug rates go up. So all these bad outcomes, but it's independent of private equity. I think, again, we need to have a uniform standard applied to all kind of corporate roll-ups, not single out one type of investor class.
One thing I will say is that, there's actually very little research showing how private equity ownership affects, for example, bargaining strategies or, how they set prices, because a lot of the work is actually being done using Medicare data or Medicaid data, but perhaps because it's more available. There's one nice new paper by Tom Lee, who's actually a PhD student from Wharton, now at MIT Sloan, and he shows that one thing that private equity firms do different after they buy a hospital is they become much more aggressive on their bargaining with insurers. And in fact, his hypothesis is that they actually threaten the insurers that the hospital might actually go out of business because of the high levels of debt.
Yeah.
And that allows them to extract higher prices from insurers relative to a non-private equity owned hospital. So I think that's one of the few pieces of evidence that we have on how they change their bargaining approaches to get higher prices. I'll also say that I completely agree that scale is important and it helps reduce costs. And we've seen evidence of that both in the private equity context and also in the non-private equity context. As you have more and more corporatization, I think the issue is how much of the cost efficiencies get passed through to customers. Whether they actually pass through these cost reductions in the form of lower prices to insurers and consumers. I think that's a question mark. I haven't seen evidence of that yet.
Mm-hmm. So I'll jump in one more time because this again resonates with me. I sit on the advisory board of a company called Rena Logic. They're PE backed, and their business model is they negotiate for self-funded plans to bring down dialysis reimbursement costs for their private payer. The private payer rate for dialysis is something like 7 times Medicare rate. It's just astronomical because we have this rampant consolidation. And so this is another example. They're passing through those costs one for one almost to their clients in the form of lower dialysis costs. It's a great example of PE working in the other direction. They're effective bargainers. They can make this happen.
So one question that's related to what you're talking about, and I don't know, Brian, if you want to weigh in also, is whether or not there's any evidence of whether or how private equity acquisitions of providers affects bargaining power with insurers. I don't know if you can even speak about that, or if you have any insight into that.
I think it's a good question. I don't think anything sort of beyond an anecdotal experience. I think it's an area that'd be helpful to see more data. And I'd say just in general on the consolidation question, I think agree with the tool. Don't have definitive data on this. I think it's certainly plausible that increased consolidation limits our ability to sort of think through how we design networks that reward cost and quality, and sort of use that network design lever. One of the principal levers we have is a plan to impact downstream cost and quality. If there's fewer, again, any sort of excessive consolidation there will limit that as a lever for us. But again, not a lot of sort of hard evidence to point to.
And one other follow-up question, Brian, that kind of came in from the chat is, are there initiatives to support independent practice providers to stay independent? Because there may be advantages to having independent practice providers.
Yeah, I saw that. I'm glad I have a chance to speak to that. So the short answer is yes. And so we want independent practices that want to stay independent to stay independent. And it is challenging, and we see that those engaged practices do often deliver concert or better outcomes. I'd say interestingly, actually, some of the they're not sort of direct care deliverers themselves, but there's some often growth equity supported companies that we sometimes refer to as the aggregators. So they're organizations that they do not buy practices, but they offer support from some of the similar types of support that a PE firm would if it was doing a roll-up, but they offer those at almost the MSO or layer on top, where they're providing resources around back office functions, population health management tools, other IT and tech infrastructure, and then also some of that bargaining power and contracting, where instead of a one doc practice having to negotiate a value-based payment arrangement with us directly, it would be very hard for them to do. They negotiate those sorts of arrangements on behalf of a large pool of primary care practices. And so we eagerly work with those organizations. We think there's tremendous value in independent docs staying independent, and want them to be able to participate in the value-based payment models that we offer, because that rewards them financially for better quality and more affordable care. It is, again, often hard to do that without some sort of aggregating function. So enjoy working with those organizations. And then for the maybe smaller, not onesie twosie, but mid-sized independent practices, we have a spectrum of value-based payment arrangements, many of which are designed in helping providers progress along that spectrum from traditional fee-for-service reimbursement to sort of upside and downside financial risk for cost and quality outcomes. And a lot of that middle ground there, especially for the practices that don't have the scale to maybe jump to full risk quickly, is around practice transformation. And so do have models in place that gives sort of smaller and mid-sized independent practices and non-independent practices practice transformation payments that allow them to essentially, fronting them the investment, so to speak, to invest in the infrastructure that will allow them to succeed in more advanced value-based payment models.
Great. So I wanted to turn a little bit to a conversation that we had when we were getting ready for this seminar. The idea of PE really succeeding in part by exploiting existing loopholes in healthcare regulations came up. And so I wonder if we could just spend a few minutes talking about what those loopholes are. And this is, the world of anecdote, but if you guys could provide some examples of what you think those loopholes are, and then some approaches to maybe either closing the loopholes or ensuring that they're not exploited in the same way. So who wants to go first?
Well, for me, the first thing that comes to mind is the surprise billing loophole, taking doctors out of network, especially in the emergency room or anesthesiologists, where you just have no way as a patient of knowing who your provider would be, whether they're in or out of network, and then getting, again, astronomical bills after the fact. And the best way to close that loophole is legislation, and they did just that, right? It's no longer possible to employ this strategy. But again, I want to emphasize, it's not private equity per se. They might have higher powered incentives. They might be quicker at finding the dollars because that's what they're trained to do, right? They went to Wharton, they have great MBAs, they know how to do this. But it's a corporate strategy, not necessarily a private equity strategy.
So if I can jump in here, I don't know if these are legal loopholes, but I think two things that we've seen, at least in our work. One is real estate is highly valuable in healthcare. A lot of these nursing homes and hospitals that they buy, actually part of the value of the deal is the real estate itself. And then they sell the real estate, and then the facility then has to lease back that same facility that they actually owned previously. They have to pay lease payments on it. Sometimes this has led to bankruptcy. So, this is something that obviously increases the value of the deal, but it's questionable whether this is good for patients. So that's something I think that needs to be thought about. The other thing is this idea of related party transactions. So oftentimes private equity firms have investments in a variety of different firms. Some of those firms provide services to the hospital or the nursing home. And then once the hospital gets bought by the private equity firm, what you find is that they also have to start now hiring these other firms that are related as vendors or suppliers. And then, that can potentially, be problematic because, they might be high priced, and that might again lead to some financial stress for the hospital. So again, I don't know if these are legal loopholes, but I think these are things that have questionable value for patients and society.
Yeah, I was going to jump to the surprise billing example as well. I think a related point, which I know some of us had spoken about as well, as maybe gets to a tools comment as well, is maybe not loopholes, but sort of amplifying, incentives that may not be optimally aligned to the patient. And I think one thing we've thought about, and as we think about the potential value of or private growth equity in healthcare and the innovation side. So we see a lot of those organizations working within or value-based payment constructs. And this notion of that all my panelists have articulated well is that, if anything, private equity ownership probably amplifies the response to the already existing financial incentives. It doesn't change the set of financial incentives. It just means people are going to respond a little more aggressively. And so I think from a payment and a policy perspective, it makes us it's on us to think through what are the incentives we're setting. And in a fee-for-service type construct where profitability is driven by more services, more higher margin services, that is potentially problematic to amplify the response to those incentives. If the incentives are set with some, tying profitability or tying financial performance to, affordability or quality, an amplified response to those incentives may not be bad and could arguably, even be good. And so again, I think, as we think about designing value-based payment models and think again at the policy level, how would things be different if the incentives were again more squarely aligned with the benefits to the downstream consumer, in this case, the patients.
Yeah, and so I think, Brian, I don't want to put words in your mouth, but I think I've written about trying to use value-based purchasing as sort of guardrails for PE, particularly in primary care. And I think that's what a little bit related to what you're talking about.
Yeah, exactly. And I think it's an area we need, more research. But I think at least sort of intuitively, it gets to this notion that, which I think is another thing we've talked about, like, PE is not good, it's not bad, it's it exists to amplify the response. I think, Ryan, you led with that. It amplifies the response to existing incentives. And so it just, is that what we should be talking about, is sort of how to right size those incentives versus what's the right financing or corporate ownership structure?
Yeah, so that raises a question I think it's worth talking about, which is that one of the Biden administration's proposals or approaches to addressing concerns about private equity is to increase transparency. Could I ask, I'd like to talk a little bit more about more specifically what exactly that addresses, and how optimistic are you guys that that's going to help if it were done well?
I think it's a fundamental problem right now in the industry. We've had RA spend the better part of 3 years trying to clean up who owns what. And
Atul and I can second that.
Yes. And as patients, we should be able to tell who is providing our care, what their conflicts of interest might be. These are just fundamental questions for a patient going into a clinic, whether it's dialysis, dermatology, nursing home. We should know where our dollars are going and if it might influence their care decisions. The fact that we don't have this, even though Medicare has it tracked somewhere in a database and you're forcing academics to clean it up, it's outrageous.
It is outrageous. I completely second that. So I think it's step one, but then I think step two is more what Brian was saying, which is accountability, and then tailoring the payment incentives to sort of align it better with consumer interests, which is what normally in other industries the market does. But as Sabrina said, healthcare market is imperfect, and so you need a little bit of regulation to nudge it in that direction.
So go ahead, Sabrina.
Yeah, I would definitely agree with that. I think the transparency will help regulators, including antitrust enforcement authorities, to identify where there may be concerns. One challenge we have in doing research is the layers of companies that are just part of the private equity model, where you have a platform, you have a platform company, you might have a holding company on top of that, and then you have sort of individual firms that may or may not have the same name as each other, but are owned by this same platform company. And it's just very, very difficult. And in particular, like just as one example of like how this can be useful outside of antitrust, there's this question, there's this big, there's concern about how that private equity just doesn't pay taxes, at the same rate as everybody else. And the IRS apparently just has trouble, doesn't have the resources to go through all the layers of companies to figure out sort of where the corporate income is that would need to be taxed at these private equity owned companies. And it's much easier to find sort of tax loopholes. So I think anything that makes, ownership more transparent is going to have all kinds of like sort of knock-on positive effects, even just beyond this, Ryan's important point of like consumers being able to identify conflicts of interest themselves. And then I guess I just, I might push back on what, this point about, if we just have more regulation, then we can solve these problems of misaligned incentives. Atul, I think that's right. If you have optimal enforcement and monitoring, and in countries where you have super empowered, highly competent state institutions, like in Scandinavia, I think we see that in action. So for example, private equity owns a lot of early childcare in Sweden, and apparently this works quite well. In the US, I have a 4-year-old, I would not send him to a private equity owned preschool. There is just too much sort of trust involved and too little, there's no, too little standardization, too little government, monitoring of what's happening. We just have to trust, put a huge amount of trust in our healthcare providers, in our schools. And I don't think the US is in a position to do the kind of enforcement and monitoring that would, for example, in the case of nursing homes, prevent profit-oriented owners from, doing too much occupational and physical therapy that's more profitable versus just the kind of like basic, turning in bed and walking people around the facility, that really might actually have, much higher value added for patients. And so I don't know what exactly the right answer is, but I guess I'm not sure that like having more rules is gonna help.
So let me clarify what I meant by more rules. I meant the kind of rules where you link payments to quality outcomes, and that reduces the amount of monitoring that you have to do of inputs, right? So you don't necessarily have to monitor, nursing hours, whether they followed all the rules, how clean it is. If you can monitor, I mean, you obviously need to monitor some of that, but I'm not saying we intensify the input monitoring. Rather, we link payments to outcomes, which are easier and easier to monitor and easier to observe, less possible to gain. And I think there's scope for some of that. I think we're doing too little of that. We're doing some of that in the hospital side, but I think more can be done on the nursing home side. And I'm not sure how much of it we're doing on just like physician practices.
Mm-hmm.
All right. I have two more questions for you. We're getting towards the top of the hour. So the first one is, we've talked a lot about why private equity enters a market, particularly in healthcare, what happens once they are there. My question is, what happens next? And specifically, what does private equity exit look like? And what might we expect to see are the potential risks in the process of exit? And so, I don't know, Sabrina, maybe you can talk more generally about like what happens to private equity investment.
So in general, private equity firms typically want to hold their portfolio companies for between 3 and 7 years, and then sell them. Try to increase value. Sometimes extract returns along the way through they earn management fees. They sometimes take special dividends from the company while they own it. But the real gains typically come from this sale that occurs at the end of the holding period. And, to a large degree, what they're going to return to investors and then also take, the cut of themselves is the difference between that sale price to another, and what they bought it for. And they get sort of the whole delta because, again, they used mostly debt to buy the company. And that sale is either to another private equity firm. So the secondary market, we say in private equity, is very active, or it's to an independent company, or it's to take the company public and list it on a stock exchange. Those are sort of the three ways that they exit. And I think, actually, there's sort of a lacuna in the literature on private equity, is that we don't often look at what happens after exits. That we often look just after they get acquired. And so I don't think there's a lot of data on, and certainly none I've seen in healthcare, of what happens after private equity ownership. I do look at it in the case of airports, and we find sort of evidence consistent with private equity improving operations in a causal way, because actually when private equity sells the airport to a non-private equity firm, we see performance deteriorate.
And I'll jump in. So Sabrina's right. There's a gap in the literature on exits in healthcare. But the best paper I've seen recently, there's a new working paper from Richards and Whaley, and they use the HCA acquisition, the largest acquisition by private equity of an acute care hospital system. And they find that basically nothing changes after exit. And they just keep doing all the same things they were doing when they had private equity ownership. So again, one case study, an important one, but we can probably rule out big effects if this is going to be the standard.
Okay. So in the last 5 minutes, I want to ask sort of a more forward-looking question related to healthcare policy. So the concerns about private equity investment in healthcare have risen to the level of the White House, which we have talked about. And the Biden administration is aiming to impose new rules about the role of private equity in healthcare as early as this summer, I believe. As they work on those rules, if you could give them a piece of advice, we'd be interested in hearing what that is. And so I'd love to hear from each of you. I will take volunteers on who wants to go first.
Well, I'll take the easy one. Transparency is for me. We've already talked about it, so I'm repeating my answer. But also, I would say, why would you single out private equity? This has come up time and time again throughout the past hour. It should be the same rule book for everyone. I wouldn't separate that, because we're not finding any empirical evidence that private equity is different from any other corporate investor. So I would make changes to rules, regulations, reimbursements that affect all corporate providers, even some nonprofit providers. Duke is pretty aggressive in maximizing revenues. They're not a whole lot different as far as I'm concerned.
Yep, there is a continuum.
I would probably echo that. I think one is to, be measured and embrace the nuance that is coming out of from the research that everyone else on the call here is leading. Is that I think what is clear is that the effects are heterogeneous, and that that's generally a recipe to not have a blanket approach to regulation and policy. Focus in the areas where we have maybe more confidence that there are poor outcomes for patients, and then we tone a little bit more in some other areas. And then the only thing I'll add is what sort of Tool and I were speaking to, which is this notion of if there's going to be regulatory and policy attention, I like the way Tool put it, so I'll steal his words, focus on the outputs and not the inputs, and that might be a more efficient way that avoids some unintended consequences.
Thanks.
I can jump in. I completely agree with everything Ryan said. I think that going down this path of coming up with rules or legislation specifically for private equity, I think might be a bit short-sighted, because this is an opportunity to think about, first principles, how would we do this for everyone? And I would just do it, in a sort of a non-specific way. In terms of the actual suggestion, I think transparency, holding them accountable for outcomes that we care about, and then perhaps linking some payments. I'm not a big fan of making drastic changes in payment contracts, but some incremental shifts just to signal that it's coming down the pipe, that this is important. I think, private equity, we have evidence to suggest that they respond to these types of financial incentives. That, and all providers would respond. So I think that probably would be enough.
Yeah, I think I will piggyback on Atul's point, although everything that's been raised is really important. I think if we're going to have private equity actively providing healthcare, then we really need to align their incentives with those of the taxpayer and the patient. And I guess my sense is that may be easier in some subsectors than others. Mm-hmm. I was looking through the chat, and some folks who are clearly, doctors in specific areas and know a lot more than me point out that actually dermatology is not so simple, and so everything is complex. But I think, I suspect there could be subsectors where it's just not, where there's so much subsidy, revenue is so separated from the consumer, and customers are so vulnerable that it just isn't appropriate to have these types of firms in the market. And and that might even apply also to other types of private, I'm not sure where exactly that stops. I think Ryan's point is a good one, that there's this continuum, and that other corporate structures, as he showed in dialysis, are also to the detriment of patients. Whereas in other subsectors, I do think there's tremendous, that the private equity has the potential to help reduce these soaring, if incentives are well aligned, to reduce these sort of soaring costs that we're seeing in this sector, and which are sort of unsustainable.
All right. Well, this has been a great conversation. I think one of the things I've learned from all of you is that, as we like to say in academics, more research is needed. So I appreciate all of you spending an hour talking about this with us. It's a complex issue, and it's great to have a thoughtful conversation about what the evidence shows and what the path forward might look like. So thank you all. Thanks for the audience for joining us, and for all of the lively conversation in the chat. We are having our next seminar on March 24th, looking at climate change and health equity. So I hope you can join us for that. Thanks, everyone.